for a really important conversation about the crucial challenge of people who are falling through the healthcare cracks. Medical research that fails to consider gender can result in faulty and ineffective treatments. Americans for whom English is a second language struggle to navigate the complex health care system, and there still are more than 1 in 10 Americans who don't have health insurance. Here to talk about these issues, we have the Executive Director of the American Public Health Association, Dr. George Benjamin. We also have with us the Executive Director of Connors Center for Women's Health and Gender Biology at the Brigham and Women's Hospital in Boston. Dr. Paula Johnson is also a professor of medicine at Harvard Medical School, and they are joined by Atlantic staff writer Olga Khazan to lead the conversation.
Alrighty, thank you all so much. And thank you, Dr. Benjamin and Dr. Johnson, for being here. This is a really big topic, so I guess let's just start with the news and sort of go from there. And the news seems to be that, Obamacare is the law of the land, and, the uninsured rate has gone way down. And yet there are still these big disparities in the health outcomes, in the health access of different communities. People are not getting the treatments that they need or, getting better, essentially. So even though now that we've expanded health coverage, maybe each of you can talk about what the biggest disparities are that you see that are still in the system that Obamacare hasn't solved yet.
Yeah, well, the good news is that there certainly has been a reduction in disparities in people actually having health insurance. But I remind people having an insurance card doesn't necessarily mean that you actually have access to care. I also remind people that only about 10 to 15% of health care actually contributes to health. And so the vast majority of the issues around the social determinants, while there are things in the Affordable Care Act and the public health side that help that, that's going to be one of the biggest issues, I think, to work out in the next few years.
So I just want to build on that because I think that is absolutely on target. And we also, given that these disparities exist, we haven't really created a unified or organized approach and making it a priority to actually decrease those disparities. And not only in kind of the area around healthcare delivery and the social determinants of health, but quite frankly, in the way that we even do research in terms of all the way from basic to clinical outcomes.
Definitely, and so one thing that I really liked about your work as I was reading up about you is that you've done some really fascinating explorations of how medical science has actually ignored gender and ignored different facets of biology for a long time and the differences between men and women. So I was wondering if you could maybe tell the story of how this happened with Ambien, which is a really popular sleep drug, and even though Ambien ultimately that was resolved, where does that kind of leave us and where is that still occurring?
Right. So the Ambien story is a really interesting one because it's a drug. Many of you may have taken it when you're flying overseas in order to get some sleep. But what they realized was that women essentially were sleepwalking. They'd taken Ambien to go to sleep, and they were kind of getting in their cars, and they were essentially asleep. And what they realized when they went back and looked at the kind of how the drugs actually worked, it turned out that women metabolized the drug differently. And you were having much higher levels in women. And it wasn't just because women were little men, right? I mean, it was really a difference in the metabolism. So it is the first drug where they went back and actually changed the dose for women. They cut the dose in half. What's important about that is that the data were there. Women were included in the studies. And the data were there. They had just been ignored. And I think that's a lesson as we think about research in so many other areas where the data are there, but they're either not stratified, and that's not only for sex, but for sex, race, or ethnic groups. So for minority women who are at very high risk for any number of disorders, how often is research performed in which you have adequate numbers to include not only women, but women of color, and where you look at the outcomes. So there's everything from basic science, female cells in animals, to clinical trials, to outcome studies, there's really a deficit in the way that research is done.
Is this still going on with certain drugs? I mean, are there certain drugs out there that we still don't know, like, whether this is resolved?
Yes.
Wow.
The data, it's interesting, there are data on the FDA website, and drugs are metabolized differently, and for many of the drugs you will see kind of the charts, but it's not necessarily translated into what you should do about it. If you looked, there's, the drugs that were taken off the market, I want to say between, it was kind of the mid-90s to the mid-2000s, there were, 8 or 9 drugs taken off the market. Half of those drugs were taken off because of increased side effects in women. So it's still an issue. Now, the good news is that for the FDA, a bipartisan coalition in the Congress has actually petitioned the FDA, and the FDA is looking into this and is making changes moving forward, but that isn't kind of looking back.
Right. Well, that's kind of terrifying. Dr. Benjamin, you were telling me a really great example about infant mortality in Maryland and how that really illustrates this concept of how better access, or kind of knowing that you have access, doesn't necessarily always translate to better care or better outcomes. Can you tell us a little bit about that?
Yeah, so one of the things that all health officers do every year is we always have the ceremonial look at the infant mortality numbers. They go up and they go down. When they go up, everyone's concerned. When they go down, all the politicians all take credit for it. And so we had one of these years in which it went up, and it went up driven a lot by the African American community. And of course, as we begin to look at the numbers, we recognize, it wasn't in teenagers, adolescents, it was in middle class, relatively well-to-do African American women. And we realized that it was due to the fact that these women now were getting fertility treatment. And fertility treatment used to be highly specialized by clinicians, OBGYN specialists who did that. And now that technology had been diffused into the primary care community. And so now you had greater access to these drugs. And now, fertility treatment, smaller babies, higher infant mortality rate. What was more interesting to me was that we decided to look back, and we realized that it actually had occurred in the white community. We just missed it. The numbers weren't as high and it didn't happen as long, so that we actually had missed it originally. So there clearly was a disparity in that, but it got picked, and it came in both races, but it got picked up doing a real targeted look at the African American community. And we see that in a variety of things.
So, it's interesting because, clearly the issue of unintended pregnancy is a major one. And, the United States is the richest country in the world. When you look at high-income countries, we have the highest rates of unintended pregnancy. And it's a health issue. The outcomes are not good. So the ability now to provide access to women for contraception is critically important, and it's a critically important health issue. What's unfortunate is that this becomes politicized in a way that draws attention away from the work that we need to do, and quite frankly, for the investment in how do we make sure women absolutely have the right access to all forms of contraception.
Right, and I think one thing you were saying is that women have to know that they have this right, and they have to exercise this right, and not just women with regards to contraception, but other healthcare consumers in every facet of healthcare. You're always hearing know your rights and go to the doctor's office and advocate for what you want. How does that end up kind of slipping away, or how does that end up not happening? What have you been seeing as far as people not maybe taking full advantage of their rights, or maybe the providers not informing consumers of their rights?
Well, I think that your last point is really important because it's not just about the consumer. So just getting back to preventative services, I had the honor of being on the IOM committee that named those 8 preventative services for women that got accepted into HHS. And a well-woman visit is an important one. It is a critically important one because it's at that visit that you are probably going to have discussed with you all the various preventative services. And what we've seen, an important Kaiser survey showed that 40% of women have no idea that that's a right. It's also pretty clear that women are showing up at their healthcare providers and being charged copays when they shouldn't. And many insurers are not really doing outreach. So it may be written somewhere, but they're not doing the outreach that's necessary. So it really has to be both, it has to be the consumer, the providers, as well as the insurers who have got to come together so that people really understand. And this is really important because cost is a barrier. And if people do not understand what their rights are, they're not going to show up.
Right, exactly. And so at the same time, there seems to be some kind of systemic bias in the healthcare system still. And there was a recent New England Journal report that showed that although it's decreasing, there's still racial bias in how quickly people get treated when they arrive in ERs. The types of treatments that they're offered. What have you guys seen with just why this is still happening in 2015? I can't believe it that we have editorials saying, oh, it's getting better, but it's still there, as opposed to it's been eliminated completely.
Yeah, we've had a very complex system, and it isn't really designed in many ways for universal access. I can tell you that I can't tell you what this is due to race, but I can tell you that I know taking care of my parents, or my mother in particular, before her death, I had to fly to Chicago because she was in the hospital, and I tried desperately while I was there to talk to doctors, talk to nurses, get someone's attention. I happened to be the health secretary in Maryland at the time for the state, and I had to get back. And so I left my business card. I can't tell you whether it was because of my business card or not, but I got lots of phone calls after that. And that's been my experience. If I go into a place and I'm in jeans and a t-shirt, etc., I get treated quite differently than if I go into a suit and tie, and that happens with regularity around most institutions. Right? People make judgments about who you are, what you do, about wealth, and that certainly occurs around race as well. It may be racial from a discrimination perspective, it may socioeconomic status. I know lots of my colleagues when I was practicing emergency medicine, tragically we didn't do this intentionally, but we often were a little uncomfortable asking someone about their economic well-being. We looked at their insurance status when we decided which prescription to write for them for antibiotics. Mm-hmm. And sometimes that colored what you wrote, meaning that you may not write the antibiotic you thought was the best for them because you knew they couldn't afford it, or you assumed they couldn't afford it. And that happens with some regularity in our system.
I think this absolutely is the case, and it's pervasive across our system. I think the question is, how do we actually measure this? How do we think about this within our healthcare environments? We are kind of undergoing somewhat of a revolution, right? We've got accountable care organizations, we've got health information technology, we've got not enough, but some investment in public health. But when it comes to the healthcare delivery system, are we really thinking about where might bias be? Mm-hmm. Where are those disparities? How are we building those systems so that we are thinking about how to resolve it? How do we connect that with our healthcare systems? And very importantly, which I think is almost never done, how do we think about that in terms of connecting with our public health system? And there are pearls out there of programs that have really been quite successful, but we're not embracing and owning what's wrong with the system in order to fix it.
Right, no. And so you're talking about the programs that incorporate, say, help you find housing once you're
right.
at the primary care doctor.
Yeah, absolutely. There's a program in Boston called Breathe Easy, and it's a connection between two hospital systems and the public health department. And what it does is, a person comes in, or a child or an adult comes in with asthma, the health information technology is connected to the public health department. Mm-hmm. The people are being treated with asthma, they're followed up in their homes, a housing inspection is done, and that's not the unique part. The important part is that because it's connected with public health, they now understand whole either housing complexes or neighborhoods that need to be cleaned up. Mm-hmm. And you know what happens when you clean them up?
The asthma goes away.
It decreases to levels that I think are shocking. Yeah. And it just shows you what our ability is today to make a difference, but it's got to be intentional.
Yeah. also in Boston, I think there was one about where they were prescribing people bikes who didn't have transportation. I thought that was neat. And you brought up Maryland, and I wanted to talk a little bit about that because Maryland has been really revolutionary in the way that they've done hospital payments for a couple of years now, and they're actually doing even more now where they're capping the total amount that hospitals can spend. I'm curious as to what you think of that, being from the state, having worked in the state, and, just sort of whether you think that will help with health disparities or whether you think there might be some negative consequences to that.
Yeah, so it's been over 30 years, actually. And Maryland is the last state in the nation that has an all-payer system. And what it basically means is that all payers, including Medicaid and Medicare, if you have an appendicitis and have an appendectomy, we pay the same for all of them, plus some other adjustments that are hospital-specific, including uncompensated care. So technically, there's no disincentive to admit someone in Maryland. With that in mind, you would think that you wouldn't see those kinds of health disparities, but you still do. But now we've renegotiated the waiver with the CMS, and in doing so, they've structured it in such a way that it is really very population-based focused. It is designed to get the hospitals and rehab centers and nursing homes and pharmacy systems and public health to collaborate more quickly and more succinctly to really look at people in a more holistic way in terms of improving health. And I think it's going to be a national model. I certainly think the all-payer system is probably ultimately may very well be something that may actually move across the rest of the country in a lot of places.
And at the same time, we're still having major issues and kind of shake-up with the existing law, with the Affordable Care Act, with the King v. Burwell case. And that has the potential, for those who don't know, to take away the subsidies from people who are in the states that didn't do the state exchanges. And so what impacts? Well, first of all, if either of you have predictions about what will happen or how this will play out, but even if not, what are the possible impacts that you think that will have on some of the more vulnerable communities in those states?
Well, the people win. That means the administration wins. I think the court will rule in favor of the administration. The implications of not doing so are horrible. The justices talked about some delaying and some administrative issues that they could do to make the impact less. I think that's silly and not realistic. The likelihood of Congress fixing this in a reasonable way, which is simply a few short lines in a bill, without all the other policy kickers that people want to play with, I think is probably unlikely to happen. Having said that, if one thinks that it's only those terrible, terrible states that didn't bring up their exchanges on their own that are going to be impacted, let's think about the Washington, D.C. metropolitan region, where Maryland has its own exchange, D.C. has its own exchange, and Virginia has a federal exchange. Yeah. Okay, but the Blue Cross Blue Shield, one of the major insurers in this area, is rating across all three states in many ways. And so if one thinks that the rates are only going to go up in Virginia and not impact D.C. and not impact Virginia, and the fact that you have people who live in all three jurisdictions going back and forth, we're fooling ourselves. So it will impact certainly those costs in those federally run exchanges, but it will also impact costs in the other exchanges. And it's going to totally disrupt patient care services, people will be in the middle of treatment, those kinds of things. So, I think it has potentially some very devastating both human impact, economic impact, and we looked at it, and about 10,000 people would die each and every year prematurely, everyone lost their insurance under this. And so it's really a matter of life and death.
And it's so, I think what tends not to happen as well, I totally agree with Dr. Benjamin. And if you look at Massachusetts, I know it's one small little state, but it is what the Affordable Care was modeled after. And if you look at what has happened in Massachusetts with regard to, let's just say, even one measure of decreased emergency room use, which is a real indicator of access and of, quite frankly, more appropriate utilization, has finally really seen quite a dip. So it's just one small measure to say it's working. This law has been a major advancement, and we need to talk about it in that way. So I do hope that your prediction is absolutely right.
Definitely. Well, we have a few minutes for questions. Sorry, guys, I'm kind of chatty, but we do have a few minutes. Over there.
Hank Wallace of Write and Speak Like the News. Are the biological demographic differences that you cite, Doctors Johnson and Benjamin, fodder for sexism and racism?
So do you mean if we actually focus on those differences that we only increase the potential for sexism and racism?
Yeah, if you follow the research, who knows where the research leads?
Well, yeah.
And racists and sexists who are just looking for info and are expecting to follow the research where it goes. But it goes with the territory, that becomes fodder.
I think that looking at these differences always can be construed in different ways. And in fact, there's a bit there had been and continues to be a bit of resistance for looking just for that fact. You know, I mean, are women's brains different? Well, you know, if you look at women's brains being different, a problem. I think we have to get away from that. We are in an advanced period where we really have incredible scientific tools. We're not using them for the betterment of our society in a way that we have the ability to, and we've just got to garner our resources and move forward.
Yeah, can they be abused? Of course, and we want to make sure we don't confuse the two. Ignorance is ignorance, and you can't make informed decision making without data and knowledge. So I would much rather get the data and knowledge and deal with racism and sexism as directly as racism and sexism, personally.
We have one more question. Anyone? Should we wrap up? All right. Well. Oh, you have one? Go ahead.
Since you mentioned data, Ed Sondik from the National Center for Health Statistics. So I'll ask a former director, since I don't want to bias this by being a member of the agency right now, but since you mentioned data, you know, we don't have a tremendous amount of data in this country on a community basis, or even a large community basis. We know a lot nationally, you know, and in some cases statewide. But really understanding disparities means getting at the smallest areas possible. But to do that, it requires resources. It requires data collection and the resources to handle that. Do you have any suggestions about how we can get more of that?
Yeah, well, you know, the ACA does require that we begin to collect data by race and gender, and I personally think we need to get it down to the zip code level in terms of being able to analyze it. Having said that, it means that we all have to advocate for more resources and spend the money more smartly. We're going to have lots of people collecting data in our nation now, with all the electronic medical records and all the sub data collection that's going to be done by the payers. And we need to find ways to exchange that data, share that data, do it in a confidential way that we don't break patient confidentiality. But the system has more data than it knows what to do with. It doesn't necessarily, as you know, have it broken down by race or gender. But we need to do it with some deliberation. It's going to require some money, but I think the investment is well worth it. And we don't need to build these big, mega computer systems to do it. I mean, everyone in this room who has a smartphone right now is being tracked. Your data is being tracked, and it's been done at a whole lot cheaper than the infrastructure that we've done for the health system.
All righty. Is that our time? Thank you both so much for this. This was great.